My name is Katie Butera. I'm an assistant professor at University of Delaware in the Department of Physical Therapy. I'm also a physical therapist. So I have a neurorehabilitation background. So I've worked a lot in acute care and inpatient rehab, with a focus on neurorehabilitation, and specifically spinal cord injury. I took a bit of a detour I was very interested in how pain impacted many patient populations that I worked with. And so I took a bit of a detour with my PhD, and I'm also a pain researcher, from my PhD work. So I'm very interested in understanding interactions between pain and movement and how pain impacts um, multiple populations that we work with. And then also my primary focus is on low back pain. So I gave Erin a title. This is the title. It is associated with what I'm going to with you about today, but I didn't have any data to present with my INBRE award, so I actually decided that I wanted to maybe take a different approach. And so I will with my presentation. So I will share some of my preliminary work in low back pain that sort of leads into this. I'm going to provide a very, very brief update. I know this presentation is already short, so I might be going a little bit fast. But I want to provide just a very, very brief update on where the progress stands with the INBRE project. I have several of my contributors on here. So one of the research physical therapists, as well as students that work with me, on the call today. And so they've been instrumental in that project. And then the main part of my presentation, I wanted to center around, I put in an R01 this past fall, and I wanted to give you just a really brief snippet of my aims and some of the reviewer feedback. And I'd really like to have a discussion, and hear any input or thoughts from others on the call on how to really address the comments. And I thought this would be a really great space to kind of hear from some outside external perspectives that maybe haven't seen my work before. So I'm not going to go into all the background that with my low back pain work, but many of you know that pain's a big deal, and that low back pain is one of the primary contributors to disability around the world. So that's really where a lot of my work centers on in this understanding low back pain and how it impacts movement, function, and disability. Um, in some of my previous work that has set up what I'm doing for what I've put in for my R01 in this line of research is a cross-sectional study in which I tested 70 people with low back pain. And my interest was centered around taking this multidimensional approach and subgrouping individuals based on combinations of sensory, psychological, and motor factors. I'm not going to get into all the measures today because that's not the focus of the presentation. But briefly, what I'll say is that what we found were two subgroups based on the measures that we used. So we had some sensory modulation measures, we had some psychological factors, and then we looked at trunk activation for the motor piece and how the trunk was active or inactive or changes in its activation for people with low back pain during functional tasks. We had an adaptive subgroup and we had a maladaptive subgroup. So we named these subgroups based on what we saw from their levels of sensory, psychological, and motor function. We found that our adaptive group had favorable coping, so they had higher positive coping, lower negative coping from a psychological perspective. They had better pain modulation, and they also had more typical motor activation patterns during both walking and forward flexion. Our maladaptive group showed the opposite. So these individuals had much higher negative coping and much lower positive coping factors on board. They showed less pain modulation, and they also showed more atypical motor activation patterns. So they didn't have this kind of nice on-off pattern that you see during forward bending and walking, but rather either showed very minimal activation or showed more sustained activation. So the pattern was just more atypical. Our maladaptive group, when we looked at all of these So in terms of all of the factors driving these subgroups, we also wanted to see if these subgroups were clinically relevant or clinically meaningful. And what we found was that our maladaptive subgroup compared to the adaptive also showed worse physical performance and clinical presentation. So they had worse performance in some of our walking tests, slower walking, as well as lower physical function. They also reported higher pain intensity as well as greater disability. So that's a really brief overview of kind of the work that's led into this. My current work, which is with the INBRE Pilot Project Award, really builds on this preliminary data. I wanted to look more at these measures, these psychological, sensory, and motor measures over time, and also be able to test and recruit and test a cohort. All of that work that I had done previously was during my dissertation at University of Florida, and I really wanted to really, establish my procedures and protocol in my lab at University of Delaware. So and also collecting that data over time. So we developed and implemented a multi-time point study protocol. We've enrolled and tested 30 individuals with low back pain at baseline 1 month and 3 month. I think we have like one more 3 month follow-up to do, but otherwise all of our data is collected. We are currently entering and cleaning the data. And also starting to develop some products for submission, including abstracts and manuscripts. And then also looking towards summarizing our recruitment achievements and the findings for inclusion in my upcoming R01 resubmission. So when I put in my R01 submission in October, we had maybe only tested a couple people at that point. Like I had not included any of the data from this pilot project in the R01, but I will in the resubmission. So I've put in the grant proposal in October of 2024. My resubmission will be in November of this year. My goal is to extend the subgrouping work and look at the subgroups over time. I want to refine the domains and enhance the subgrouping approach. So looking at some other measures that may fall into the sensory, psychological, and motor domains so that we can really see if we can replicate the subgroups and if there are more clinically applicable measures that could be used to subgroup individuals in these domains now that we know that these 3 domains are in fact important. Establish the predictive validity. So not just are these subgroups associated with clinical presentation or clinical measures, but do they potentially, does your classification in a subgroup at baseline predict your outcome down the road? So looking at a longitudinal cohort study design. And this is really looking towards setting the stage for a future intervention, development, and testing. In physical therapy, we use, as many of you can guess, we use a lot of exercise, but there's a lot of combinatorial approaches that we can use with looking towards some psychologically informed strategies, as well as sensory and motor activation strategies that may be important for certain individuals with low back pain based on some of our subgrouping work. But we can't do that until we really know more about the subgroups and really have an established way to classify individuals in the subgrouping or into these subgroups, which at this stage we don't have based on the number of participants, and also because my previous work has only been in a cross-sectional design. So I really want to leave some time for discussion. So I'm going to go really briefly through these and I can always go back. But my aims, I'm just going to share my aims with you and then the some of the primary critiques from the reviewers. So my first aim was to determine multidimensional subgroups of individuals with low back pain based on modifiable sensory, psychological, and motor impairment domains. So really looking at adding in those original measures that I used from the cross-sectional study, but adding in some additional measures. Some that we used can be used in clinic and others are less feasible from a clinical perspective for physical therapists to implement in their daily practice. So we're looking towards adding some more feasible measures to see if we can make this classification a little bit more applicable to clinical practice. We want to test whether, once we derive those subgroups, test whether they have different outcomes over time. Very interested in looking at, we think that we hypothesize that the group or the groups with greater dysfunction across the domains are going to have significantly worse function and pain at that 12-month follow-up. And that they potentially may show a longer time to recovery. And then the last aim is to explore whether sensory, psychological, or motor impairment changes from baseline to 6 months are predictive of changes in function and baseline, changes in function and pain from baseline to 12 months. So what we're looking at here is really looking at whether how your sensory, psychological, and motor factors change, and whether that has a contributing factor to like what we're seeing clinically, and things that can be assessed in clinic, how those change, and whether that predicts your clinical outcomes. So just as a larger a big picture overview. So my proposal was not discussed. It was a little it was definitely disappointing when I heard that, but I think that's this is a great place to share that information. I've still had a lot of when I saw it was not discussed, I was frustrated because you don't get the comments for a little while. And then when I got the comments, I actually felt a little bit encouraged, because I felt like these were things that I could really address and that I just needed to tell a better story. And so I'm excited to kind of share a little bit of the comments and see what you all have to say. So from reviewer, and of course, this is just a snapshot of, the larger review, but in the reviewer one, I think they really didn't understand the subgrouping approach, and they felt like this was a very incremental advance on the current state of the knowledge, and some concerns about some of the measures we were using. From critique two, I think, based on their scores, they seem to actually really like the proposal. They, I think, had more methodological concerns based on sample size and things like that I definitely think we can address in our approach section. And then critique three, I was okay. I think that this person also had similar concerns to the first reviewer, where they weren't quite understanding why we were doing the subgrouping and doing, I think the replication they weren't really sure why we needed to do replication. And then also that if we already had previously established measures, why are we adding new ones? And whether or not these measures, some misunderstanding of the measures, whether they were rigorous, repeatable, and equivalent to our established measures. So just real quick, there are consistent themes for significance. Really, I wasn't able to get them to recognize how rigorous subgroup work is needed to develop this personalized care pathway to really tailor treatment in a future study. I think there's some misunderstanding of rehabilitation care and measures. So, that comment about measures being rigorous, repeatable, these are like a lot of these are, established measures that are very common in rehab. So I think talking about that a little bit more might be important. And then concern that we weren't including other known pain-related factors, non-modifiable factors like age and sex, or non-rehab focused measures. And so I think me doing a better job of, really showing that like low back pain is a big condition with a lot of factors that impact it, and that we're very focused on the rehab piece and the things that physical therapists themselves can address. And not that they wouldn't work with other disciplines, but that's where the focus of this project is. Innovation, there was concern that replication is low innovation and that our methods aren't novel. So I didn't really do a good job of highlighting why replication is necessary, and then also that the methods might not be novel, but the combination of these methods is. And then from the approach, low sample size, limited generalizability, concerns about low sample size and limited generalizability. I think that was a misunderstanding of that the goal is to look at all these measures, but that statistically we would reduce that so that maybe only 1 or 2 measures would need to be used to put people into these subgroups. and just some misunderstanding of the importance of choosing subgrouping measures that are specific to rehab and our interest in pain and movement compared to other factors that may be important like age, sex, social factors, things like that. So I know that was a very quick overview. We only have a few more minutes, but I threw up a few discussion points. I'm happy to hear other input that people had. I can go back to things, but general input or guidance for a strong one-page response. Maybe how to highlight some of the things that I've said I think I need to highlight. And how to change the reviewer 1 and 3's perspectives. And then also my grant submission went in before the new scoring criteria, and the resubmission will go in under the new simplified review framework. So if anybody has any experience with that recently or any input, I would be happy to hear it. So thank you.